Well, actually, that's the direction I wanted to go, was how do you build this to do it right? It sounds like what you're flagging, anybody who follows in your footsteps needs to watch. What's the baseline of procedure activity?
Yeah, and that's exactly the key point, is that alternative payments should enable providers with the current budget to do better for the patient. Everybody's talking about triple aim. We always talk about quadruple aim. The staff, their work quality, if they enjoy their work for us, even as the same level of relevance. So if you have a provider that says, listen, we are very conservative in our treatment. We only treat if there is clinical relevance, and we know that from data. But they say the fee-for-service model limits us in flexibility, and to rearrange our organization and to work more integral and to innovate, then a bundled payment adds value. Because then you say you have one price for the whole patient journey, and we stimulate you to step out of your traditional footsteps, the way you work, and look at a more innovative way on giving patient care. But if you have a provider that is over-treating, you sort of incentivize them to keep over-treating. So you must be very accurate on when you use bundles, using it in general and saying we skip fee-for-service and go directly to bundled payment is with a lot of risk and a lot of technical issues implementing.
I want to spend a little more time on the hip and knee bundle, for example. Why does it by bundling that payment, why does that necessarily mean you'll continue to get too much volume? Are there prior authorizations or some kind of criteria before the procedure would be permitted in the first place?
Well, I think that depends on the system characteristics where you're talking about. In the Netherlands, we have no prioritization for hip-knee surgery. Each hospital has their own, they are able to make their own decisions on that. What we do is, with a lot of analysis on practice variation, look at what is the optimum level. That's one part. So you try to look at what is the reasonable level of treatment. Once you have a bundle, you get a different incentive. If you have a bundle where you reward for quality, the incentive will be to include as less complex patients as possible, because your outcome will increase. And this is a problem because, and we saw it at some points, and you now see literature on it in the international research, if you have a level of quality and you want to maintain that level or improve it to get a higher part of your shared savings, you see that the catchment area of those organizations grow because they are looking, and I'm not saying that people are frauding, but it is a mechanism that will increase, that they are looking for patients from other regions to have patients who, with the highest chance of good outcome, will include, so they raise their quality level. One of the control mechanisms we do is that we define the catchment area of a hospital when we start a bundle. So we say all the patients with that procedure in your catchment area is included in your bundle, apart from the fact if you treat them or not. And if you have, say, Amsterdam, and you have one hospital, and a very complex patient will be treated in another region, that could be done by the hospital to lower the risks of complication and increase the chance of savings. And that is why we include it in the contract of that hospital to say, even you didn't treat that patient, it was in your catchment area, we still take it into account for your savings and your quality measures. They didn't like it, the hospitals, but they now see the reason why we do it, and they feel more obliged to also take care of those more complex patients.
What about risk adjustment? A lot of people would simply argue for risk adjustment to compensate for that.
The problem with risk adjustment is that we had a lot of discussions about risk adjustment with both hospitals and doctors. And if risk adjustment, of course you need it, but because risk adjustment calculations are very complex, and sometimes very unclear from a clinical perspective, risk avoidance still takes place. So you can do a risk adjustment, but that doesn't mean, because doctors don't understand if patients come to them, whether there is a chance they have a high saving or not on that patient. Even if you have complex risk adjustment mechanism, you still have the fear of, is it a profitable client? And I'm putting it very black and white now. What we learned is that if you do risk adjustment, you should do it on characteristics a doctor can see and understand. So if you do risk adjustment where you say you get a higher price if someone was acute hospitalized in the year before, they can see it in the medical records, and then they know, okay, I get a higher price for this patient, and now I know what my position is. If you do it only on statistical grounds, not transparent for a doctor, you don't solve this behavior at the front gate. That's our experience.
Wanted to get a little clarification. So on your bundles, it sounds like they're population oriented, because you talked about shared savings being related to the market footprint or the service area, and you talked about it for the population. Most of the bundles I've seen have been individual patient oriented and not related to a population. Can you explain a little more clarity on the bundle and how the population plays in versus just one patient at a time?
Yeah, this is a very relevant difference. I have to put it in 3 blocks. The population bundles we have are in primary care only. Because if you have a GP and the GP has, say, 3,000 patients, reward them for the average cost of medical expenses for cardiovascular care for the whole population. So not only for the patients, but for the whole population. And the reason why we do that, if you would reward them for the average cost for a patient, you would stimulate labeling people as patient because you get more money. And you wouldn't stimulate prevention because it is very difficult once someone has cardiovascular disease to dramatically lower the cost. So we say we divide those costs over the total population and lower that, which makes them more looking for patients in an early stage. So that's only population based.
And I'm sorry to interrupt. So then in that GP perspective, that would include all conditions, all total cost of care?
No, only cardiovascular. So we look for all patients for defined list of DRG codes, medicine codes. Those are strictly defined. We defined the bundle together with doctors, which creates lists of hundreds of medications and billing codes. And for those specified group, we look at the costs of the total population. In the hospitals comes the point you address. Do you pay for an individual patient, or do you pay for the total population of that hospital? The reason why we explicitly choose not to pay for an individual patient is then you have 2 problems. You have the problem of the risk adjustment, because then you need to risk adjust, and you have the problem that you don't take into account the volume of patients in that hospital. I'll try to explain. If you have hip and knee surgery and you have 2 hospitals, one has 30 procedures a year and one has 500 procedures a year, the ability to influence costs and quality in the one with 500 is much bigger than in the one in 30. That is why we don't use risk adjustment, because we don't pay separately for one of those 30 in those hospitals. We say, no, we take the average costs of those 500 index year and take that as a level, because then you include all the patient characteristics and you have your case mix adjustment. So we have minimum volumes for bundles. In general, we say don't start a bundle if you have at least 250 patients, otherwise you get very complex case mix adjustment calculations. You stimulate value at a much too low level of treatments in a hospital. We know that quality and volume is related. So don't try to stimulate volume in a hospital which by definition hasn't a low number of procedures to have quality at all.
Now, does this work better in a metro area or a service area where you only have one hospital and so they're getting all the volume for cardiac, let's say?
Yeah.
Or is there a different dynamic if you have three hospitals that in essence compete with each other in that same area and they're each trying to get the Silver Cross cardiac volume? Does that change the dynamic?
We are in sort of point where this comes into stake. The bundles we have are still separate hospitals and GP groups spread over the Netherlands. We are now at the point of scaling up. And we are exactly in the middle of this decision. What do we do? Do we first give all those hospital bundle contracts and then see how patient streams go, whether they all go to one hospital or they go to another hospital, because then you get a higher volume, and let the market do the competition? Or do we first make at a regional level agreements with hospitals who will specialize on which patient group? If we're now in Amsterdam, we have a number of hospitals here, and we are in the middle of this discussion with those hospitals. Who is going to focus on cardiac? Who is going to focus on oncology? Because if you rearrange the market to create more volume, the travel distances are almost similar if you go to one hospital or the other, but if you have two hospitals giving the same procedure, you never will get the volume and experience to get quality. So we decided first to get more focus in hospitals on which are the patient groups they serve. And then we set the next step on alternative payment within those hospitals to accelerate. That's why we did the HIV contract. The hospital we did the HIV contract with has about 30% of the market share for all HIV patients in the Netherlands. It's more concentrated in the Amsterdam area. They have the largest share. So they have about 2,500 HIV patients, which that volume is so high, we don't need to talk about risk adjustment, because if we have the average historic prices as a reference point, it is already case mix adjusted.
That's great. This is a different way of thinking about bundles than a lot of people when they talk about bundle hip and knee, like in the US. It's my grandmother goes in for surgery, there's a bundle and it's for her.
Yes.
And it starts on this date or when she receives this initiating care, maybe the primary care specialist consult, and it ends after so many days post-surgery or therapy or whatever. So this feels almost like a hybrid between that definition of a bundle and a population.
Yes.
Because what I see you doing is it's a population-based payment, or capitated, I'll say.
Yeah, it's a mixture. Yeah.
Based for a patient type.
Yes.
Like cardiac.
Yes.
And that's exactly why the case of you described, what we try to prevent is that if you define bundles in that way, you're constantly looking for average patients with average cost structures. But we know they don't exist. So if you make it an individual payment and you try to make it risk adjusted, you still have the issue that the bundle is not enough for the care needed for your grandmother. If you say it's an average price, at a year level we middle out. So one is much more complex, one is much more cheaper, but it middles out. You get much more freedom at the care provider, because in your context they still are incentivized to limit care, because they know if the end of the bundle comes inside, we have to get rid of your grandmother. I'll put it a little bit black and white. But if you say this on all the people with hip and knee in your hospital and you have the 300 in a year, it's an average price, and you see the floating average every month going up or down, you know, oh, I'm on the green side. And you don't do it at an individual level. That's the big difference.
It sounds like at Silver Cross you've done a lot of different experimentation with alternative models in a lot of different settings.
Yes.
Across the continuum of care. Can you pick the one, or maybe one of the ones that you're most excited about or that's been most successful, that we could really focus and drill in on that one today?
Our most successful alternative payment models are in primary care. And the key structure of those models is that we use them for cardiovascular disease and for pulmonary disease. You have the whole chain of care. If cardiovascular disease is not managed well, people may be hospitalized or have medication. And what we do is we pay the GP at a population level to stimulate prevention and early detection of high-risk patients. And we reward them for lowering the integral costs and increasing quality for those two patient journeys. And we've done them now for one is for 7 years and one is for 4 years. And we have very good results. We see the total cost going down. We even see the incidence of people with pulmonary disease going down. And because there is no incentive to be ill, and normally you only get paid for pulmonary disease if you have the diagnosis. But if you pay for preventing pulmonary disease, you even see the incidence down.
So what you wanted to talk about the general practitioners and focusing on heart disease, pulmonary. Was there a problem in the country or at Silver Cross where you chose that? How did you choose what problem to solve?
Oh, that's a good question. We started our alternative payment program about 7 years ago. And it was the moment where value-based healthcare was really getting on track. Everybody was talking about it, and everybody was talking about, well, what's the role of the healthcare insurance company? So we said we're going to start a program where we want to experiment and learn what our role is and what alternative payment means and how we manage it in our claims processing architecture. And then when we started, there were, I think, 30 or 40 projects that said, well, pick us, we want to do a project with Silver Cross. So what we did was we chose contrasting projects, not based on financial potential or based on quality issue, but we arranged a group of projects just to have contrasts in learning. So those two were primary care groups who already were very patient-centered and very focused on population approaches. But we also choose 3 projects in hospitals, one on HIV. We defined a bundle on HIV. We did one on cardio stroke, which is our most complex bundle, and then one on open heart chirurgy. And we choose them to learn. The open heart procedures was too complex. We put a lot of time in it and we didn't get it working because it was too complex. There was too much money involved and the uncertainty for the hospital was too big, so we had to stop it. The HIV one in the hospital worked very well, but the most spectacular results were in the primary care. And the reason why I think that those alternative payment models worked well is because the patient group involved as a percentage of the total population of the provider is quite high. If you have cardiovascular disease at a GP level, the prevalence is 30%, I don't know, something like that. So a high percent of people in the GP is included in the alternative payment model. If you have a hospital and you do open heart chirurgy and only 0.5% of a department is included in the bundle, it is such a small fraction of the patients they see on a daily basis. It's more theoretical project than an actual day-to-day project where you can learn from. The patient group is so small. And that is one of our key learnings, is that if you want to do alternative payment, you really need to have a substantial group of patients directly identifiable by a healthcare provider to intervene. If the group is so small, you don't get the change you want. And everybody's talking about integrated practice units, but it's a theoretical concept because you can't organize healthcare in first dividing all separate integrated practice units because you had to rearrange all healthcare. It's not possible. You can't separate all those units from their original background. So that's our key lesson. You need to have sufficient volume to get it working.
That makes sense, and I think I see a lot of of models focusing, well, we'll do diabetes, heart disease, very prevalent. You talked about pulmonary. Prevalence varies, but that's certainly up there. Interesting you point to HIV. That one's not terribly prevalent,
No.
thankfully, in most societies. How did you decide that was one to pursue, even though the prevalence was low?
Yeah.
That's a very good question, because one of the problems with bundled payments is that, well, we call it garbage in, garbage out, is that if you have hip-knee replacement, it's very common to do bundles on that. But the problem with those two is that there is a lot of practice variation on how often you intervene and what your clinical cutoff point is where you intervene. So you see that some hospitals, the chance of being treated are much higher than in other hospitals. And we thought if we do a bundle with those hospitals, you include the over-treatment in the bundle. And we had no experience with how to manage that, and that's why we took HIV, because there is no practice variation on the diagnosis. You have it or you don't have it. And that is why in the experiment we were very glad to do it, because there is absolute no debate on whether a patient is included in the bundle, which is a problem on itself. How do you find a patient you include in a bundle? And there is no debate on whether the person has a disease which you should treat. And therefore you can focus on the integral cost of care and the complete patient journey and outcome. And I'm really glad we did that, because one of the lessons we learned is that the first step, if you want to do a bundle, is make sure that the provider has an acceptable range of treatment. If you have someone who's over-treating, never start a bundle, because you keep the over-treatment in the bundle and you sub-optimize and you pay too much savings, because well, I'm going to really into the technical details now, but if you have a hospital which has a lot of patients and they over-treat and you want to lower costs and improve quality, the first thing they will do is stop treating after they close the contract, and you will pay too much savings because you included too many patients into it. But that's very technical now.